So we hope next 15-20 minutes will keep you all awake. That's our target. So we actually took out 4 cases which we managed. We had a series, but we took some prototype cases. So I'll just give an example. Some of our known, the director's family's cousin was undergone a LSCS, and in the middle of almost 11, 12 o'clock, we get a veteran call that the patient is an atonic PPH. They tried everything, and in the middle of the OT, they did a subtotal hysterectomy, and they are still not able to, and the blood products were ordered. You all understand all the hospitals were not backed by all kind of protocols, which will be discussing here. So at around 11 o'clock, we as a team flew there, and it was such a, what you say, unexpected, terrible experience for all of us, the team there, for us, and everywhere. And then we were all aware we were pumped some of the blood products, give it Tranexa, packed that abdomen with mops, tightly sutured. I was in the ambulance, transferred here, and this lady went home in the couple of days, and I will not go through that details what happens. What I'm trying to say is these are young, otherwise healthy females. In critical care, it will be a lot of, if you see my ICU or any medical ICUs, you will see the age group between somewhere to 12 to 14 to 80, 90 years with a lot of comorbidities. But which I'm talking about, you save them, they will be normal back, and so not one life, maybe multiple lives with that. So I will not dare to go into the OBG part of it. I'll stick my whole discussion into critical care and ICU component of it. So these are all prototype cases. A 35 years old G2A1, 35 weeks, 6 days with a lot of comorbidities, undergone a LSCS with those risk factors. And after the LSCS, she had a atonic PPH. And as you all expect, hypertension, requiring volume, requiring some amount of vasopresses went on. And the regular standard oxytocin, methazines, and different OBG component were taken care. As I told, I will not dare to go into that component. Now, if the patient continues to worsen and bleed, and continues to have a hypertension, then we were in deep trouble. Either it is in your hospital or anywhere in the world. And PPH, unfortunately, is one of the preventable cause of mortality or maternal mortality. So we were all talking about when we discuss this kind of patients who actually land up in hypertension and organ dysfunction, then we call as a massive transfusion protocol. So the massive transfusion protocols are one component which come into any of our mind when these situations come. So I will probably take Dr. Ravi to ask questions related to. In these scenarios, this all happens in unanticipated middle of the nights or in some holidays like Sunday or a public holiday, when none of us are anticipating and you just went for a normal cesarean section and you land up in. This is not uncommon, right? So we all come across this. So what is that which we are talking about, massive transfusion protocol, and what is that different from the obstetrics point of view, Dr. Ravi?
I think the requirement of blood in the OT when you are doing a cesarean section, the anticipated blood loss would be somewhere very minimal. But the key point here, what you have to ask yourself is my patient bleeding more than excessively what I am anticipating? That should be the triggering point here. And rather than reacting, you should have a proactive approach where you should have a protocol in place. If my anticipated blood loss is exceeding, then somebody should really activate the massive transfusion protocol where already the blood units are in place. When you press that, then the units are delivered to the OT straight away without any cross matching.
So how do you define them? Suppose you said unanticipated, more than what is expected bleed. How do you define them?
So if you are requiring more than 3 units of blood in an hour, where you are transfusing the patient, or when you are replacing more than 50% of the patient's blood volume. So these are the general triggers what you look at in general for any other patient when you want to activate this massive transfusion
that's
protocol.
A very well summarized point. See, what we all as a clinicians in polytrauma use is you lose all of your blood. Suppose I as a 70 kilo person has a 5.5 liters, I lost all the blood. That's a probably a person who is actually. But that is all about in 24 hours, massive transfusion protocols in a trauma. But what happens if it bleeds in a half an hour time, which is more commonly happens in most of the PPH cases. So we talk about if there is almost, if you see the protocols talks about if you lose a 50% of the blood or you needed 3 units of transfusion in a quick time, you are in a terrible situation there. And the second component we are talking about is systolic blood pressure and heart rate. If we say systolic blood shock index or a index which talks about your tachycardia is more, your systolic blood pressure is less, then you are in a trouble there. So these are the 2 points where we activate a massive transfusion protocol. This is very theoretical, okay? We all talk about it, so-called institutions across the globe. The evidence of these protocols being available and being active is always a question. Now I'll ask Dr. Anitha ma'am, what is the availability of these protocols? We'll come back to what is that protocol, how we follow. But is this protocols available? How many of us really worried about these protocols?
Yeah, I think wherever we have practice of tertiary care practice, where we come across many high-risk conditions, every institute should be adept with all the blood transfusion component facilities and also adept with the MTP protocols. It includes a team approach where an informer presence, a guide will do the job of doing all that, and the transporter gets all that. It should be done because it is valued time. So we have to have it, and it's not that you get 1 pack cell of RBC, 1 of PP. It's an approach where a component of 1:1 ratio of sets of 4, as some estimate on the amount of, as you said, the vitals of systole or diastole or the rate or the oxygen saturation fall. All these taken into account, the surgeon or the anesthetist would be in a position to estimate what is the requirement, or in a scenario, then they should make it a possibility to have at least 4 of each.
So you being a part and heading a unit, how frequently it been practiced? Either it is in a corporate tertiary care unit and your unit.
Yes, Dr. Venkat, being in the government institute, we are the last recipient of all these awards, actually. So we have a lot of referrals like this. So most of the time it happens when it is a comorbid condition. So in a year, I think, if I remember at Nilofer, we have done MTPs to an extent of 10 to 12, 2 digits. We also had an experience, a lasting experience of managing a placenta previa case also, where we went viral also into the national channels, where we had to transfer totally 60 components. Though we had 7A, as we discussed in the morning, though we had factor 7A, we had to. And then we also had a peculiar case of P-null woman. A very rarity, and that was an opportunity for all of us.
We always discuss about code blues, any hospital, anywhere, after a patient getting into a cardiac arrest or in a decompensated state. But if you look at the outcome of a code blue is extremely miserable. Okay, the hypoxic component, the neurological outcome. This is one of the easiest way where we can save lives, and it need to be exercised not on the time of a PPH. It should be done in advance. It's a protocolized. It should be made available in your hospital. There should be an exercise. There should be a drill on this. And your blood bank use should be available. That first, if you have a PPH, who will carry a blood sample to the lab, blood bank. And in the blood bank, are they alert that code blue like thing, code MTP, massive transfusion protocol. So they know a code has been announced from the OT, and they have a component. In polytrauma, we use O negative blood. Here, if there is a cross-matched available blood, 3 units packed in one single box should be transfused, or you take your own way, 2 or 4. It is all up to. But this should be available. What generally happens after the PPH, we try to do all this exercise and run around. That's not possible, and this is one of the easiest way. The other components they were talking about is tranexamic acid. Most of the units who receives a gram of tranexamic acid followed by another gram in 8-hour infusion. Now the debate where 1:1:1, 1 packed cells to 1 plasma to 1 RDP. Is it enough, or can we use 2 packed cells to 1 RDP to 1 FFP? So this has been a recent data which we are evaluating. Ravi, any insights onto that?